Welcome everybody, and thanks John for your introduction, and maybe not thanks to Simon because it's a very hard act to follow, but I'll give it a shot. So I want to talk about immersion pulmonary edema. It's probably quite important for this forum because it is probably a very under-recognised condition, and many of the deaths that have been attributed to drowning were in fact from immersion pulmonary edema. So John said I work in the new Fiona Stanley Hospital. That's a picture of it, and that's a picture of our chamber complex, which is a triple lock think 6 ATA capable chamber, which we treat about 40 divers a year at our institution, and we do routine hyperbaric treatment for wound healing and other conditions about 5 days a week. This is our main lock looking towards the entry lock here and the dive chamber there. So the dive chamber and this lock can be pressurized at different pressures at different times. So two different treatments going on together. This is the entry lock. Also got a toilet facility either for patients or for staff. And the control panel for this chamber doesn't have any gauges and dials. It's all electronic and controlled by a very experienced technician. And we also have two monoplace chambers for which we also use for treating decompression sickness for appropriate cases, usually milder cases, and we can do treatment table 6s on this. But anyway, back to immersion pulmonary edema. So immersion pulmonary edema is defined as development of pulmonary edema, which is really fluid on the lungs in divers and swimmers while they're immersed. So they need to be in a liquid medium. So in Australia, we call it, and the UK, we call it immersion pulmonary edema, so IPO. And the Americans call it IPE because they spell edema differently. And in swimmers, it's called swimming-induced pulmonary edema, or SIPE, and also scuba divers pulmonary edema as well. So it affects divers and snorkelers, which is what I'm mainly interested in, but also typically combat swimmers who have head-out immersion, and Navy clearance divers working out of Sumu in Sydney Harbour, they do strenuous swims across the harbour, and a good proportion of those actually do develop immersion pulmonary edema during these swims. And also triathletes and open swimming water competitions. In triathletes, the only time they get pulmonary edema during a triathlon is during the swimming leg. So that's from the immersion. And we see numerous cases during the Rottnest Channel swim, which is from Cottesloe in Perth to Rottnest Island, about 20 kilometres off the coast, involving several thousand competitors. And we see numerous cases of this every February when the race is on. The risk factors for pulmonary edema, the most important one is if you've had it before, perhaps up to 30% recurrent rate. Females probably have about 7 to 1 higher incidence of IPO, particularly older women in their 40s, 50s and 60s, and we don't know why that is. And other risk factors can be divided into intrinsic and extrinsic. So females, I've said, older divers, high blood pressure, heart disease, excess prehydration before a dive, and dives involving lots of exertion. But some of those affected won't have any of these. And some of the extrinsic factors are colder water, but it has occurred in tropical waters. Rebreather divers, particularly those using rear mount rather than front mount rebreathers. And if there is a faulty regulator or tight wetsuit or BCD causing increased resistance to breathing. With immersion pulmonary edema, it typically occurs actually quite early in the dive. So it may occur with this ascent, and symptoms often worsen on ascent. And part of that probably is related to the lower partial pressure of oxygen as the ambient pressure reduces during surfacing. This is a photo from Rottnest Island of the Shark Cave at the west end of Rottnest. That's in about 20 metres of water, lots of grey nurse sharks there, harmless, Will. And it's important to recognise, particularly in the older diver, that immersion pulmonary oedema can be a sign of underlying heart disease, and this needs looking into and fixing if amenable to correction. It is often recurrent. Fatalities have recurred, and John has been involved in the publication of a diver who was an older female who had an episode, had a full workup, and then went back to diving, had no problems for quite a lot of dives, and then had a fatal episode of immersion pulmonary oedema where she died on the surface, being retrieved back to the shore on a shore dive. So full workup doesn't guarantee that you won't get it again, and if you do get it again, you can have a bad ending. So depth itself, there's no known association between immersion pulmonary oedema and decompression illness. The only real mitigating factor of depth limitation is it means that you won't get decompression sickness we shouldn't get decompression sickness if you have a profile that's a no decompression dive. And certainly there'll be cases of IPO recurring in scuba divers who have stopped diving but have been swimming, and including in pool swimming. Another grey nurse shark at the shark cave. So the clinical presentation of immersion pulmonary oedema is that typically divers get short of breath, breathe fast, they cough, and typically cough up either blood or pink frothy sputum. And because they've got low oxygen levels, because their lungs are flooded with fluids, they become blue on the lips and the tongue, and often quite rapidly lose consciousness, then go into cardiac arrest, and sometimes can't be resuscitated and die. What the diver or the buddy might notice is that the diver has a cough. The diver appears to be breathless, using more air than normal, so producing more bubbles than normal. And the diver themselves may think they can't get enough gas, so that their breathing supply or regulator is faulty, or they're running out of air. So there's some of the typical features. Diagnosis, obviously, having features of pulmonary oedema associated with immersion. And when we listen to the chest with a stethoscope, we can hear crackles, crackling sounds and wheezes, whistling sounds on examining the chest. And these can be focal, so may only be on one side or the other, or may typically just be in the anterior chest, because usually that's the position of the lowest point when a diver is diving or coming to the surface. We can use an ultrasound to detect this in the emergency department, and imaging of the chest, such as a chest X-ray or a CAT scan, to confirm it. First aid, the most important thing is to remove the diver from the water and sit them up if they're conscious and give them high flow oxygen. Keeping them warm helps because it vasodilates them and then reduces the amount of blood going back to the heart. And then contact emergency services and arrange emergent transport to hospital. Once they are in hospital, our treatment is to support their respiratory system, and that may require them to have a CPAP mask, which some of you might use for your sleep apnea, useful for that. And that really just drives back the fluid that's in the lung alveoli back into the bloodstream. And we might use fluid medication intravenously, or even vasodilators. So when we see divers who have had this before, they say, "Can I dive again?" And I go through them the risks and say, well, we need to do a full workup on you, fix anything that we can. But even if we do that, it may happen again, and if it does happen again, it could be fatal. So I often give them a copy of John and Carl Edmonds' paper of fatal cases. I'm very wary about advising divers that they are safe to return to diving following an episode of immersion pulmonary edema. So the SPUMS position is to advise against diving unless there's a clear equipment cause that has caused it. And perhaps if that's the case and someone is keen on or is returning to diving despite your advice not to, perhaps let them know that they need to have a buddy that's aware of what's happened before, how to deal with it, and having oxygen immediately available on the surface should some symptoms return. And we only tell the diver what the risks are, and it's up to them to accept the risk if they choose to dive again. So SPUMS at the moment is in the final stages of preparing a joint position statement along with the UK's Diving Medical Committee on immersion pulmonary edema and diving, and hopefully that will be available in Diving and Hyperbaric Medicine Journal by the end of this year, and also on the SPUMS website. And that's the end of my presentation. So that's Kat the dugong from the Cocos Islands that John mentioned. So unfortunately, I don't think Kat is still there, hasn't been seen this year or last, and probably gone back to Indonesia. So thank you for your time.